Good evening, everyone, and welcome to DocToks with Dr. Forrest Tennant and friends. We have a special surprise for you all this evening, and so we'll go ahead and let Dr. Tennant take it away and welcome everyone. Thank you so much.
Thank you, Jamie. Tonight, I should first tell you that the educational part tonight is really directed really at people with adhesive arachnoiditis. Those of you who have other conditions might want to listen in because some of this may apply to you and some of you may not. But this show is directed right at those people who have both adhesive and non-adhesive arachnoiditis. And what I'm about to tell you tonight may be as important a message as I can ever deliver to you. Later in the show, we're going to get back to having Pat Irwin and maybe some of her guests talking about our medical board education and advocacy program, which needs to go on. And particularly after you hear my education part, it's the kind of thing that medical boards need to know about. I want to call your attention to a meeting that was held in France, specifically Chambéry, France, in the year 2010. That conference was called the International Congress on Arachnoiditis and Tarlov Cysts. And incidentally, we have our arachnoiditis conference next week in Colorado, and I believe it's the first conference that's ever been held on this earth since 2010. So 15 years has gone by before there's been a conference on adhesive arachnoiditis or Tarlov cysts. At any rate, at this meeting, they invited all of the world's experts. Some of you are familiar with people like Sarah Smith or Dr. Aldretti, and they had people from a lot of different countries that assembled there, and their idea was to share what did they know, what could they recommend, and where did they stand at that time. Now, I can tell you that in 2010, I was starting to become quite aware of arachnoiditis simply because it was starting to show up almost as the number one cause of seeking treatment for intractable pain. So I was already kind of alert to this conference. I wasn't internationally well known at the time, so I wasn't invited, but I certainly was on the receiving end of what they said. Now, they said something at this conference, or two or three things, which are terribly important. First off, they had no idea what to do about ongoing treatment for the disease. That didn't. But they all agreed on one thing, and that one thing is that there was one of the corticosteroids called methylprednisolone that would suppress adhesive arachnoiditis, or at least the inflammation of adhesive arachnoiditis. They all agreed on that. And they came out of there recommending emergency treatment. And they recommended that if someone had the signs of adhesive arachnoiditis after surgery, they should be given intravenous methylprednisolone, 1,000 milligrams a day for 5 days. Now, we don't do that high these days, but that was the dosage they recommended in 2010. And they all agreed with this. Now, why did they agree to this? Now, here is a message that everybody with this disease, and perhaps other intractable pain diseases, needs to know. Prior even to 2010, there had been a number of studies showing that the only drug available that would suppress inflammation and promote healing in the spinal cord was methylprednisolone. Now, I've actually put together here a bibliography on these studies, and I've got 9 on this sheet. But what I'm going to read you a couple of the names, for example, of these studies, and some of these were done prior to the year 2010, and these esteemed people internationally were aware of these studies. For example, I'm going to read you the title of a couple of these. Methylprednisolone inhibits production of interleukin-1, beta, and interleukin-6 in the spinal cord following compression injury, spinal cord injury in rats. Here's another one. Efficacy of methylprednisolone therapy for the injured rat spinal cord. And there it goes on, and there's a whole list of these. And these studies were done prior to 2010 and afterward. But these esteemed people were aware of these studies, and enough of them had given methylprednisolone intravenously to people with adhesive arachnoiditis to know that it was the one drug that would suppress the pain and the inflammation of adhesive arachnoiditis and prevent it from developing. That they knew. What they did not have any idea about, but they wanted to figure out how to take this drug and make it to where it could be used on a regular basis for treatment, but they didn't know how to do that. That's where I come in. Okay. Now, after this particular session, I got very interested because I was aware in 2010 of some other studies going on. I was kind of connected at that time with a group of holistic and alternative doctors who were studying particularly fibromyalgia, and they were also studying adrenal fatigue. And what they had learned was that there was a way to give what they called sub-replacement dosages of corticosteroids without harming anybody or causing adrenal shutdown. Now, they did that work with plain hydrocortisone, but I thought, if they could do it with hydrocortisone, why can't I figure out how to do it with methylprednisolone? So I want you to know, for the last 15 years, I have taken those recommendations and tried to figure out how to use methylprednisolone for adhesive arachnoiditis. And I've come to one conclusion, a little bit like the people did in 2010. You really can't treat this disease without methylprednisolone. And I'm going to cover some of this in just a moment. But again, I want to make that point and this. To me, it is the essential drug. It's the one drug we have that will suppress spinal cord inflammation and promote healing in the spinal cord. But there's also another study of mine that I know about that I'm very, very high on. Okay? I'm going to read you the title of it, and you'll kind of get some idea why this drug is really the backbone of our treatment. Now, the study I'm about to read you does maybe have some applicable to CRPS, abdominal adhesions, post-traumatic brain injury, and some other things. This study is called The Effect of Methylprednisolone on Neuropathic Pain and Spinal Glial Activation in Rats. What this study showed was that methylprednisolone not only acted in the spinal cord, but acted in the brain to deal with glial inflammation and centralized pain. And boy, do we need that. So when we administer methylprednisolone to patients, we not only get the spinal cord effects in the cauda equina and the arachnoid, we also are attacking centralized pain. And in my opinion, you cannot get good pain relief in adhesive arachnoiditis unless you're taking both methylprednisolone and opioid drugs. Let me repeat that. I've learned one thing. If you want really good pain relief in adhesive arachnoiditis, you're probably going to need to take an opioid, maybe low-dose naltrexone, which is a semi-opioid, but you're going to need an opioid drug and you're going to need methylprednisolone, and that I have learned. Now, I'm going to go ahead and show you a little bit about how methylprednisolone has learned and what I have spent 15 years working out. Like I say, my biggest contribution to this disease may be that we have figured out how to use this drug because it really is the backbone of treatment for this disease. First off, what about emergency treatment? Now, the investigators there in 2010, they knew to give a very high intravenous dose of methylprednisolone. Now, today, we're recommending that after an epidural, after a lumbar puncture, after surgery, if people are starting to develop symptoms of arachnoiditis, such things as terrible pain in their legs, their buttocks, water's running down their legs, they got a terrible headache, they can't stand up, they're just sick, then we're recommending you can go ahead and use intravenous methylprednisolone. But I've seen success with dosages ranging from 100 milligrams a day all the way up to 1,000. I think most of your centers that do the intravenous methylprednisolone average about 500 milligrams a day. Now, I've developed an alternative protocol because a lot of people who have epidurals or lumbar puncture, for example, right after delivery or after a lumbar puncture, don't have access to intravenous methylprednisolone. So what I've done is develop another protocol, and I'll tell you what it is. It's a 6-day Medrol dose pack. Now, if you don't know what a 6-day Medrol dose pack is, Medrol is the trade name of methylprednisolone, and it comes in a nice packet, okay, for 6 days. And every nurse practitioner and doctor knows about this pack because they use it and they know it's safe. And I'm telling any doctor or nurse practitioner who has to deal with an emergency situation, you give them a 6-day Medrol dose pack, but add to it ketorolac, that's Toradol, 30 milligrams or 60 milligrams a day for 3 days. And then I throw in progesterone for a week. And why progesterone? It too has been shown to heal spinal cord injury. And so I try to put the three together. It's a nice, simple protocol that any nurse or doctor anywhere on this planet can use. And I've gotten a lot of great reports back from that. Now, what about the next thing you need methylprednisolone for is flares. Now, all the time I hear from people with adhesive arachnoiditis who are in a flare, and it's terrible. You go along with your life, and all of a sudden you're hit with that terrible pain that throws you into bed. You can't function, you can't think, you can't do anything, you're just paralyzed. Now, what do you do about that? Methylprednisolone is your answer. You want to go and you want to get an injection, and I recommend an injection of methylprednisolone of 10 to 20 milligrams, either subcutaneous or intramuscular. And you can add ketorolac to that. You can add dilaudid to it. You can add B12 to it. In other words, but for severe flares, again, methylprednisolone is the one drug we have that will usually break a flare. The milder flares, you can also go right to your doc or nurse practitioner and say, look, I needed that 6-day Medrol dose pack. A lot of times that's all you need. So either a 6-day Medrol dose pack, or if you got a severe flare, try to get your practitioner to give you an injection of 10 to 20 milligrams IM for the flare. Now, let me go on to talk about the one, and this needs a real sales job because nobody likes what I've now learned that you have to do for adhesive arachnoiditis. And what I have learned is that you need to take a very low dose of methylprednisolone on an intermittent periodic basis. Okay, you've heard of low dose naltrexone? Well, this is low dose methylprednisolone. How low? We recommend that people with this disease start off with a low dose, 4 milligrams. That's a piddly dose, twice a week, Monday and Thursday, that's all. And if you don't like that dose, go with a 10 milligram injection once a month. In other words, a very low intermittent dose. And you can add to it if you want ketorolac on opposite days. You can take herbals with it. You can take opioids with it. You can take a lot of other drugs with the methylprednisolone. It doesn't have any real interactions with any of the drugs that we use for this condition. But let me again say what you want to use this drug for ongoing maintenance. Some people may have to take it all their life, and I'll tell you how long you have to take it. But I recommend with every case of adhesive arachnoiditis that you start off with a methylprednisolone of 4 milligrams 2 days a week, let's say Monday and Thursday. If you want to go Tuesday and Saturday, that's fine. But 2 days a week, you skip days in between. Okay, now that's a very low, safe dose. That's not going to harm anybody, but I can tell you that it has a great effect on adhesive arachnoiditis. The inflammation of adhesive arachnoiditis doesn't have to be treated every day. It's sort of like you've got to tackle it every few days to suppress it, but you don't have to suppress it every day. You can skip days, but still get a great effect. That's why a once a month injection can actually be quite helpful. So that's one thing we've learned. You don't have to do the corticoids each day. You can skip days. Now, what I want to cover now is, first off, how long should you take the methylprednisolone? What I recommend to people is this. When you're on a maintenance drug, and what you want to shoot for with adhesive arachnoiditis is what I call stability. Now, what do I mean by stability? I mean by stability is that you can wake up in the morning and know that you've got an opioid drug or other pain relievers, and that you can get through the day with your pain where you're comfortable. You can function like a normal human being. You can walk, you can go to the bathroom, you can urinate, you can defecate. In other words, you can function pretty darn well doing activities of normal living. And you know that you can relieve your pain with the medications that you're taking. That's stability, okay? Now, those people that are watching this that are bedbound already, a lot of this may not apply to you because I'm well aware that you have great damage to your cauda-equina nerves and arachnoid that may be just damage, not even inflammation. So what I'm telling you may not apply to you, but it does apply to anybody who's got adhesive arachnoiditis who is ambulatory. If you're still walking, you need methylprednisolone. That's my general rule of thumb. And when do you reduce it? You reduce it when you have your pain permanently reduced. When you know that your pain is down 50% of where you started, start cutting your medicines back, okay? But as long as you've got the pain with adhesive arachnoiditis, you need methylprednisolone. If that's 6 years, 30 years, or a lifetime, so be it. Now, people with rheumatoid arthritis and a lot of your autoimmune diseases have to take corticosteroids for life. You may have to with this condition, but it beats letting that disease get out of hand. You've got to stop the deterioration with adhesive arachnoiditis, or you pay a terrible penalty with a shortened life that's miserable to boot. So the benefits far outweigh the risks, and that's where we're at with this drug. What I want to do to close out with this, however, is talk about medical ignorance. There is not hardly a day I go by when some doctor tells me I will never prescribe a corticosteroid, or a patient says, I can't take steroids. Well, it turns out that they haven't gotten the message. Somehow or another in the medical profession, the concept of taking low-dose corticosteroids on an intermittent basis hasn't reached the average practitioner. And they still think that a piddly dose of 4 milligrams a day of methylprednisolone is somehow dangerous. It is not dangerous. And you can take 2 dosages a week, 3 dosages a week, as long as you skip days, they're fine. But we have this bias out there among some doctors and nurse practitioners that they just think this is dangerous. Well, what's dangerous about corticosteroids is a fact. There is a danger. Now, what is the danger? The danger with corticosteroids is when you take them daily at a dosage of what we call above replacement. Technically, that's about 20 or 30 milligrams of hydrocortisone a day. But in other words, if you want to take, let's say, 12 milligrams of methylprednisolone a day for 10 days in a row, yeah, you're going to have side effects. But we're saying you don't do it that way. You take a very low dose periodically, you skip days so the adrenal gland is not affected adversely. You don't have this burnout of the adrenals. You don't get osteoporosis. You don't get cancer. It doesn't interfere with any of your other drugs. But there's a bias out there and a belief among what I call ignorant doctors and ignorant nurse practitioners. I'm sorry if you're called ignorant, but you should know this. This is out there, and anybody who's kept up with this should know this, okay? And I want patients to know this, and the new group of arachnoiditis educators to know you can take low-dose naltrexone, low-dose ketorolac, and low-dose methylprednisolone very safely and effectively to tackle this disease. So, and again, let me just summarize it, and perhaps you picked it up. Dr. Purcelli, the medical director of our foundation in our research unit, we don't start anybody with adhesive arachnoiditis without methylprednisolone. We consider that the backbone of treatment. We start with that drug, and then we add opioids, we add ketorolac, we add herbals, we add hormones, we add electromedical devices. In other words, you start with this as the fundamental treatment and you can add to it. So that's where we're at. I think it's essential. I would not personally want to treat anyone with adhesive arachnoiditis without ongoing maintenance with methylprednisolone. So I'll leave you with that. That may not help, may not suit some of you very well, but nevertheless, I've got to call it like we've seen it and what we've worked on this for 15 years, treated hundreds of patients, and this is where we're at on this message. With that, I'm going to sign off on methylprednisolone, but leave you with it that, yeah, we have one drug and only one that we know will consistently suppress spinal canal inflammation and promote healing both in the glial cells in the brain as well as in the cauda equina and arachnoid of the spinal canal. So with that, Jamie, I hope we have Pat Irwin here, or Monty, are going to come in and talk to us about this very important program.
Yes, sir, we do. Welcome.
Well, Pat, I'm glad you have the first team here, and you're going to tell us about this program. But let me just introduce it by saying medical boards in states not only discipline doctors and do regulations, they set an attitude. And there's a lot, and most people on medical boards are not physicians. They're lay political appointees. Most of them are very good people that want to do the right thing. And we're going to see that they do the right thing, right? So with that, Pat, I'm going to turn this over to you. Tell us about the program and invite your guests to just say, where are we going with this?
Thank you so much, Dr. Tennant. And thank you everyone for being patient with me for the last 4 weeks. I think some of you know I have a family member who has had health conditions that have needed my attention, and I know I kind of disappeared for a month, and I want to thank everybody for hanging in there with me, and I've gotten a lot of support from all of you. So thank you so very much for understanding. It means a lot. The other big change tonight, which I'm thrilled to announce, is Dr. Ibsen is going to partner with me. We're going to do this session together, and that will continue, at least for now, on a monthly basis. Once I get my family situation settled, hopefully we can go back to biweekly. But for right now, it'll be monthly, and we kind of have to catch up where we left off. So just a quick summary. If you remember, we've had 3 separate sessions on how to influence your medical boards. We started with how DocToks and the National Campaign to Protect People in Pain, we're going to join into a new alliance, which we have, and we're very proud to let you know that Dr. Tennant has officially joined the Speakers Bureau of NCP3. So welcome, Dr. Tennant, and we're just thrilled to have you on the Speaker Bureau. It's an honor to have you there. We're very, very pleased. So welcome. The other thing we covered in the sessions was some of the strategies that we were going to think about, and I will let Dr. Ibsen, when I'm done with my piece, talk a little bit more about the strategies that he has seen work. And I have to say, seeing the effort that was put into Montana, you guys knocked it out of the ballpark. It was incredible. So really, really a team effort. And I think the strategies that we learned from supporting Dr. Ibsen in that event, we'll call it, we can really leverage to looking at other state boards. So I will let him talk more about that, but really way to go, everyone. It was an incredible effort on everybody's part. The other thing I do want to mention is that the slides I'm going to present tonight were done by a wonderful advocate we have. I don't see her on here tonight. Her name is Vanessa Ott, O-T-T, and she's from Hawaii. And she volunteered to not only do the slides, but keep track of this program for us, all on her own time. So kudos out there to Vanessa. Yay. And I'll make sure that she knows that, we're all very grateful for the work that she's done. So the slides I'm going to show you are not my work, but Vanessa's work. And she really did a great job on that. Red wanted me to remind you, and I'll tell you what's on here. Remind you of two things. So Red has two announcements. The first is please do not forget his CME course. It's continuing medical education. He has a 1.5 hour course that you can take virtually. There's a link for it. And you don't have to be a physician to take it. It's helpful if you have some medical background, but honestly, I think all the people I see on here, just being a pain patient, you've picked up on the terminology, and it really does not require you being a medical person. So go ahead and take a look, and you don't have to answer the questions at the end for the credit, but it's really worth going through. So I'll post that link again, and really, really great program. The other thing he wanted to remind everybody about is using AI in a positive way for doing your searches. So I'm not sure how many of you use AI like perplexity.ai when you're trying to look something up. Like, let's say you want to know who are the people on the Montana board, right? And there's all kinds of ways you can do it. You can go to their website, you can track down this or that. But a very easy way to do that is put in Perplexity AI, and you're going to search on that, and it brings up and I'll say a vetted list that it has checked against a whole list of resources. So you don't have to trust that it's giving you solid information. It's going to give you the sources at the top. So there's very, very, I want to say, solid information that you can get when you're doing your research. And Red suggests two questions. I think the first one's hysterical, but it's a good one. He says, be sure to ask, what are the best online search engines for investigating? You could put the Montana State Board, adhesive arachnoiditis, whatever it is. So you're asking the AI to give you the best resources. I love it. Hey, AI, give me the best resources for giving me information on, yeah, whatever you're looking up. And then the second one, and this is really helpful because I tend to get far too wordy when I'm asking a question to Perplexity, is what are the most important factors, right? You're asking Perplexity in adhesive arachnoiditis or strategies for influencing the medical board, whatever it is. So those two questions, what are the best online search engines? What are the most important factors, are two questions that might get you some really solid information in a quick way. You can still use Google, but I don't know about you, but Google has just, I think, started to fail us all. You get more garbage than you do good information anymore. So that's Red's suggestion for both of those. So we will put that there. Okay, here is the work that Vanessa did, and you're gonna I hope you can see the pictures. Can you see the pictures, Jamie? Okay, so we want you for NCP3 and DocToks, right? We want you guys. And it's because of the state board initiative, which we've talked about before. How are you going to influence your boards so they're giving physicians due process, and they're not retaliating on patients for asking legitimate complaints? This is a reminder that the two groups are working together, DocToks and NCP3, and that we've had 3 sessions already on the state boards, and I'll post this for you guys, episode 19, 21, and 22. This is a recap of the 3 sessions that came before, and basically all it says is what is our goal? What are we trying to do with the boards? We're trying to get rid of the false narrative, right? Where they're still saying opioids are evil, you can never use them under any circumstances, and any physician that prescribes is not legitimate. We want to restore the doctor-patient relationship, which they've completely trampled. And we want to assure patients can obtain their medications once it's ordered. Now that one is more the pharmacy board rather than the medical board, but we really want to work with both boards, both the medical board and the pharmacy board. And we talked about a few strategies, which was listening into your board meetings, and learning as much as you can about the board members. And I know that was one of the strategies you used when working for Dr. Ibsen, is I was so impressed with people knew who was leading the group, who was going to be on that day, what their background was, were they medical, were they legal, were they, who were the people? Because in knowing the people, that's how you know how you're going to influence them. Some boards, like we talked about, have 8 physicians on it. So some boards are completely physician backed. Some boards might only have 1 or 2 physicians. Every single state board is very different. So of all the things you can do, what you did with Montana is perfect. Learn who's on there. What's their background? When they get up to speak, how are they approaching pain management? How are they approaching the doctor-patient relationship? Really listen for those key things. Now, switching to the contact list, I know a lot of you have already given me your name, number, serial number, background. But for those of you who haven't, we're going to be sending out both emails and information on DocToks, requesting again for people to sign up. We need you. And the 2 categories are, one would be a state coordinator. Both of these are valid. State coordinator would be someone like Kristen or Monty who say they want to jump in and take a leadership role with that state. Vanessa has agreed to be the state coordinator for Hawaii. But you can still be involved even if you don't want to be at the state coordinator level. You can be an advocate, and we still need all of your information on that too. So if you get an invite, if you get an email about the program, that's what it's about. For those of you who have already responded, and I know actually I'm looking at everybody out here, I would say I've already heard from 80% of you out there, but if you haven't, be sure to respond, or if you want to give us additional information, like what's your Facebook page, if you want to share your phone number, you don't have to, but we would love to have that, whatever information you feel comfortable sharing. Which leads us to, what data are we going to collect? Vanessa, where I found this woman, do not know. She has updated my tracking grid was in Word. So Vanessa took everything I had done and she just made a really nice Excel spreadsheet of it. Thank you, Vanessa. And so now we can track, we can group, we can track, we can essentially write reports on how we're doing. So you don't have to know the details, only this is the information that we're going to be collecting. Okay, I'm almost done. Last but not least, she will be coordinating, reaching out to everyone. And her name again is Vanessa Ott, O-T-T. And I will put this out there. Her email, and she wants everybody to rate her, is msvott, V-O-T-T, @gmail.com. So if you see her or her name, that's what she's asking for. She's collecting information for the database. Same thing we talked about a month ago, only much nicer, much better laid out, a much better database for sure. Okay. So that is all I have tonight. Before I turn it over to Mark, does anyone have questions or comments on the State Board Initiative? Where we're trying to go?
We did have Donna Wilkes wants me to send you her info, and then
Wonderful.
Teresa also didn't see where she was supposed to leave her email, so those are 2 more.
Perfect, perfect. Thank you so much. And you can also leave information. I'm always looking at the comment section after the meeting, so I'll be happy to take it from there. And we'll go into more detail next week. So Dr. Ibsen, you're here, and I'm so happy you're here to talk about what happened in Montana. Please tell us the good, bad, and the ugly.
Okay, thank you for the invitation. I'm happy to be back. So what happened in Montana was we wanted to have everybody participate in the meeting, and we asked them if everyone could, and it was up to me to waive my privacy rights so people could be included. And they declined to waive my privacy rights so people could be included. So, so that's one middle finger to all of us from the Montana board. I want to rewind just a second and acknowledge and admire Mr. John Flannery, who I think has figured out a very great way to deal with medical boards who want to deprive us of our due process rights. And how he did that is the usual screening panel meeting is a subset of the board, and they generally meet with the doctor that they have a complaint about. The doctor's not allowed to speak. Their attorney's not allowed to speak. The board presents a case, and then they go into executive session, which is attorney-client privilege, they called it, where the attorney for the board is meeting with the client, the board.
The board.
Now,
They made the board the client. Yeah.
so essentially, they're saying we're going into this session for attorney-client privilege, and it's like, wait a second, my attorney's here, and I'm the client, and I'm the one with the privilege. I'm the one with the accusation against me, and they just didn't listen. So what happened next was the attorney for the board began to present the case, and I'll just do that briefly. I can't remember the case now all of a sudden. So essentially, we're talking about a well, anyway, I can't remember the case. So I'll tell you this way. The attorney started to present the case. Oh, yeah, the case involves a nursing home patient who contacted me because her pain was not being treated. The doctor at the nursing home was quite amenable to having a conversation with me, and so we had that conversation. The doctor at the nursing home was intimidated by her doses. They would only go to 15 milligrams of oxycodone 4 times a day. This is in a lady who fell out of a 2-story window, broke her pelvis and her elbow. She'd been in pain management before, and she knew that when she was in pain management, she used 30 milligram oxycodone. So she's was asking for that, and they categorically refused. And I told this doctor that I'll do it. And she said, okay, please do it, because the patient was irritable and restless and uncooperative and wouldn't do her physical therapy because she was in too much pain. Also, parenthetically, she had a non-union of her elbow fracture that they never paid attention to, so she was in agony from that. So all of this complexity, it turns out that the supervising doctor at the nursing home did not like me prescribing to this patient and filed a complaint against me immediately. She had an inept complaint. She had the details of the patient's anatomy and the timing of her hospitalization wrong. It was a pathetically lame complaint, which I could not snuff before going through this whole thing. So the attorney for the board began to present the case. And I said, wait a second, there's a long tradition in medical training that the doctor who's on the spot, in any case, this is grand rounds or any kind of review, the doctor presents the case, like in an educational format. And the attorney was, he didn't use any swear words, but he said, no, I'm going to make the presentation. And then I said, well, then is it okay if I do the legal summary after this is all over? Because he doesn't belong in my lane and I don't belong in his. And I think I made my point. So after he presented this case, which is inept, and his presentation was inept, then they decided to go into executive session for 40 minutes. At that point, my attorney protested vigorously, saying it is not due process to have a hearing and pretend that it's not a hearing and go off by yourselves and talk without us being able to hear what you're saying. So we don't know what your evidence is. So how can we respond to your complaint? And I know that they didn't have the evidence because they never talked to this patient. They never talked to the doctors involved. They never did anything. So at any rate, 40 minutes later, a little bit of hand wringing on my part, they came back and the doctor said, well, we're going to have to dismiss this case. Like he was disappointed. Um, so we won another case in a hostile regulatory environment. And I'm thankful to Mr. Flannery for that. And I'm thankful for the doctor that filed the complaint who did it so poorly. Um, uh, Ultimately, I think I have to do something to stop this flow of complaints because there's more in the pipeline. And I have now, over 19 years, won 13 cases before the Board of Medicine, which is gratifying, except when you tally up, it costs about $20,000 to $30,000 to defend each case. So I'm broke, but I've won. That's the story of my life. I, um, um, I love to be right, but not at this kind of cost. So it's still hostile. Subsequent to that, um, um, the meeting ended, and just a week later, another case has come up, and we have a deadline of August 11th for that. And they know that I have a federal case I'm preparing for on August 25th. So they're just hitting me with a two-front war here, and I have to fight it that way. They get to do that. They don't get to be ethical or moral or scientifically accurate or anything like that. It's just up to us to present key data to the board members. And I think if you present the data to the doctors on the board, you can do quite well. The only problem is the lawyers have hijacked the board. So, and they don't know enough medicine to be doing this job. So I hope I answered your question. Anything else?
Dr. Ibsen, thank you for that summary, because I definitely think everything that you've learned we can use with other boards. And so maybe to look at that whole concept of due process, how would you recommend someone else from another state, Arizona, California, whatever, if they're working with their board, what do they need to present to their board regarding this disciplinary process? What would you say?
Well, it's a scary thing to go before your medical board. They have a kind of a star chamber atmosphere, and it's highly authoritarian. So I don't know. Uh, well, Flannery says it this way: you cannot propitiate an evil God, which means you can bring all the donations you want to the church that you're going to, but if your church is that of an evil God, you're not going to get what you want. And so I think that clearly what's happened with me and the board is I'm transparent. Most of my colleagues, and me at first as well, when I was first sanctioned by them, I was embarrassed, humiliated. Um, it was so unfair. And it felt like they were sending me to the gulag, which they did. So the shame and humiliation of it are techniques that they use to get you to be afraid, and to shut up and to not assert your rights. I did the opposite. I was quite public about it all. And I think transparency is the key thing. Even though you're ashamed of what's going on, it's actually worse what they're doing. So I decided that I would not necessarily worry about my own ego in the situation, but present the best case I could in order to keep my license so I can continue to serve my pain refugee patients.
So,
Transparency is it.
Dr. Ibsen,
Assertiveness is it.
thank you. And Brandon, I'll get to you in a minute. He has a question too, but I want to make a key point to everyone who's listening. So if you heard what Dr. Ibsen was saying, it's the transparency. And I think using that word is very powerful when you're talking to the board about how they are disciplining physicians, is that it is a non-transparent, for the most part, process, and it is also an equal power base in some of the disciplinary actions that Monty and I have seen. The attorney for the AG's office, it does not matter. It did not matter what the other attorney for the physician said. Whatever came out of that attorney general's attorney, the AG's attorney, that's what was taken as gospel. And so I think it's lack of transparency and the power difference. Brandon, what were you going to say? Can we unmat?
I got it. Yeah.
Thank you.
The power of the Constitution versus truth law and common law. We have to understand the United States has been acting in a corporation. That's a government alien. They're not even elected officials. The Attorney General is violating the Constitution by practicing medicine without a medical license. I've seen Nikki Haley do it in Arizona. You can ask Barbie Engel. This is how you do it. You make them show them the power of the bond. The governor has the highest bond. Okay. The governor is to protect every citizen in that state. Now you can go directly to them and you need to be stern. I am practicing as a person. You have no jurisdiction over my person. And we can each state get together, 7 of us, and find them $2 million per person. So that's 7. That's $14 million. And once you start talking common law and truth law, walking in honor is walking in truth. Walking in ignorance is walking in lies.
Thank you.
Thank you, Brandon.
Thank
The
you.
power of the Constitution. Hillsdale College will give you a free one.
I think the key thing for us to remember is that pain reigns on the blue and the red and the purple. And there is no political division. Pain doesn't care who you vote for or what your values are or who your God is. Pain does not care. It's a equal opportunity perpetrator, and we need to respond to it in a unified way as best we can, and realize that it doesn't matter where you were born, how tall you are, how fat you are, how old you are. Pain can come and get you, and we got to keep making that point. So thank you, Brandon.
Mark?
Yes. Go ahead.
Mark, I'd like to ask you a question.
Sure.
You said that the doctor came back after their powwow and came back and said, we have no choice but to find you innocent, if you will. What did he mean by that? I mean, what do you think was on his mind that they had no choice?
Well, I'm pretty good at reading body language. And I think in the February case, this Dr. Geyer, received some heat for dismissing my case. And there was definitely tension between the lawyers and the doctors. And this tells us a story that it's the lawyers on the medical board who are officially assistant attorney generals of the state of Montana. It's the medical board is a subset of the Department of Justice. It has nothing to do with medicine. So this tension between the doctors and the lawyers, I think, was really evident in this case. And those lawyers are angry at me for winning. And, God bless them. They're going to keep getting angry because I'm going to keep winning because we have the facts and we have the law, and all they have is their emotional response to this. They seem to be convinced that I'm a bad person and they must take me out. They almost have, it's a scapegoating kind of a situation, or a witch hunt, however you want to put it. But they don't like losing, and they've lost 2 in a row. You'd think they'd stop, and I got a 3rd one coming. So I think that the more these happen, and the more it reveals that there is some sort of agenda going on here about the legal system wanting to be in control of the medical system. I mean, basically, the lawyers are taking over medicine, essentially.
And Dr. Ibsen, if I can just say, you point out again, I'm looking for things we can use for other states, and it's powerful. You have to know the people on the board. So in your case, if we had gotten directly to the physicians on the board, in the future, focusing on those doctors, perhaps, or who is ever in the discipline, there's often physicians in that disciplinary process, we may have had even more strength than you had going in. So really knowing the people on the board, who sits on the board. And in this case, I think you're right. I think for a lot of cases, the physicians on there have a very different viewpoint of what the non-physicians or the attorneys have. So I think that's something we want.
Well, and the physicians are also ill-informed, as I was before I got into pain refugee management. So they need to be informed also. But you make a good point. And one thing I forgot to say is at the beginning of the meeting, they have an open session where the public can ask questions and make comments. And I think 11 people were able to make comments at the beginning. The only way they rejected a comment from a person is if they mentioned my name. So you can't discuss the current agenda in a meeting. For some reason, they have those rules. So what I noticed is everybody was really smart lab rats, and they realized, oh, they'll shut me up if I mention Dr. Ibsen, but if I just mention pain, they won't. And so they got a lot of information delivered to the board or to the attorneys that are listening. And that was very effective. The other thing to mention is that there were 50, again, we overloaded their system, which only goes to 50 participants in their Zoom call, and there were people who couldn't get in. So 2 months, in February and in July, we overwhelmed their system.
Yeah.
That's
a very good, that's a very good
rewarding for me.
That's an amazing strategy.
Thank you, everyone who showed up. Even if you didn't get this, even if you had to sit there twiddling your thumbs, wondering what they were doing to me, I can tell you that I survived. I can say that it's highly rewarding to see that many people show up. So thank you.
Yeah, you're welcome, Dr. Ibsen. You're welcome. And thank you for presenting that this afternoon. I think this evening it has been very powerful for all of us. And we're there with you for your next case as well. So we're still with you.
Stay tuned.
Stay tuned. We haven't forgotten you.
Speaking of next case, just really briefly,
yes.
My federal grand jury case is on August 25th.
Okay.
We're not asking for a big turnout for that. We want to treat the federal U.S. attorney with kid gloves because my intention is to convince them not to indict me. Obviously, my attorney's intention is to make sure I don't go to prison. But my intention is to realize that if I get indicted on that day, all of a sudden 80 people are opiate refugees again. So I want to make a level-headed, I might put some tears in there, but a level-headed presentation to the grand jury with just the U.S. attorney present. My attorney won't be present. And pray for me that day because I need to be level-headed, sensible, dispassionate. We'll see.
Are you talking about the new Attorney General, Pam Bondi?
Yeah.
Okay. That's all I need to know.
Yeah. Yep.
So time-wise, Jamie, I know we have 5 minutes left. Would you or Dr. Tennant have further information to present? I want to make sure I give enough time for closing. Dr. Tennant, do you have closing thoughts for us tonight?
Just one thought about Mark's case and something I've observed over the years. It seemed to me that Mark had a case in which a patient there were no complaints about this patient as long as she was getting a certain low dose of opioids, not enough for treatment, and Mark treated her appropriately. But there is this belief that a dosage above some level is a crime these days. Okay? It's not whether you need it, it's just that a lot of people, particularly in the departments of justice, feel that if you go above some level, like the CDC levels, that it's a crime. It's not a misjudgment of clinical practice. It's not even necessary. It's just that it's just flat wrong. And somehow this is just nonsensical, but we've got to work to overcome it. And in my experience, it's the dosage that people would need moderate to high dosages of opioids, and the doctors who treat them are just absolutely wrong. And I don't know quite how we get around this, but it's out there, okay?
Yeah.
And that's why.
Maybe a federal case will do it.
May. It sure may. And anyway, with that, again, Mark, thanks for sharing. Pat, let's keep going with this. And medical board experiences or just have to be part of what we're after today. again,
Absolutely. Thank you,
thank
Dr.
you so
Tennant.
much. We'll
Thank you so
carry on.
much.
And
Bye,
again,
everybody. Thank you.
Good night.
Thank you, everyone. God bless us,
Yeah.
everyone.
We'll see all of you next week.
Thank
Yes,
you.
thank you, Dr.
Night.
Janet.
Have
Thank
a good
you.
week.
And go to
You
Hillsdale
too.
College and get you a free constitution and read it.
Thank you all. Thanks so much, everybody. Thank you all.
God save the pain warriors.
Thank you, Carson.
You bet.
Leanne, thank you.
You're welcome.
Thank you, Dr. Marcus. God bless you.
Just say no to injustice.
Amen to that. Due process.
Yes.
I love you,
Do
people.
not ever let them tell you.
No, be careful who you say no
No.
to injustice to.
Yeah, exactly.
I was given these rights by my creator alone. And Justice Clarence Thomas, oh, he's had a remarkable story. You can go to Truth Plus and watch it for free. Beta tester, they give you 1 month for free.
Thank you, Brandon.
Thank you so much.
And you
Thank
can
you.
see David's interview on Lindell Network.
Oh, good.
David Smith. Yeah,
Yeah.
perfect.
Mhm.
Excellent.
Sure enough. God bless.
God
Bye-bye.
bless. Thank
Loving you all.
you. Good night. We love you all.
Love y'all.